want to thank the organizers for giving me the opportunity to talk and share our work. This is an excellent morning. I really enjoyed it and learned a lot about Chiari. And it's difficult to follow an excellent talk, but I'll try my best. So these are my current funding sources, but none of these are directly related to the work that we did. And I want to acknowledge here that this work was done while I was a fellow in Toronto in Dr. Hodai's lab. And the folks who are involved are listed in the paper as well. Francesco is a neurosurgeon from Italy who's trained in functional neurosurgery. He's with me in the lab now. Philip is a medical student in Toronto. Dr. Miklas is a neuroradiologist in Toronto. Matt Walker works in Dr. Hodai's lab. Gavin is a medical student now at the University of Toronto, and of course Dr. Hodai is the PI for the project. So what I want to do is, a lot of it has already been, the stage has been set, and people have discussed this paper before as well. So just briefly mention the challenges and how can we leverage neuroimaging to answer some of these challenges. A little bit about FA, and you've seen other slides as well on this. And how did we set up this study? What was the hypothesis, cases, controls, and what kind of structural imaging analysis we did? Some of the results. And then, since this is such an august audience and knowledgeable about Chiari, the last part I wanted to throw out some of the questions that we don't have answers to, and maybe seek some discussion on that as well. And how can, learning from this study, how can I plan a better study in future as well? And so we diagnosed Chiari's based on symptoms, and we had a discussion earlier today as well. A lot has to do with patient presentation and the clinical symptoms, along with this finding of tonsillar herniation. And all of us know that it doesn't correlate well with clinical severity of symptoms that the patients have. And a lot of these patients have brainstem dysfunction, Erb's and gag reflex. They have dysphagia, dizziness, sensory problems. Someone mentioned about axial instability as well, motor weakness, and none of these previously have been shown to correlate with degree of tonsillar herniation. People have looked at other structural metric as well, posterior fossa volume, and they've shown to have poor correlation as well. And so we need a novel imaging-based sort of assessment of what's happening in the brainstem in these patients. So this was the sort of working idea behind this. And a little bit about diffusion tensor imaging. So at the level of each voxel in multiple different directions, the diffusion of water molecules is first assessed. Once that is done, then the tensor model is applied. And in 3 different directions, the magnitude of the tensor is calculated. And so once that is done, there are 2 sort of forks in the road at this point. One is to take this more towards a tractography where you track white matter fibers, and the second one is to take it more towards calculation of fractional anisotropy in each of these voxels to really understand the microstructure in different structures. And so you create a FA map, and FA is calculated by this formula. The FA map, if you look at it, the darker regions means the volume of water is homogeneous in all directions, and so these are isotropic voxels, while the voxels in gray and bright colors are the ones that have anisotropy. So there is a preferential direction of diffusion of water molecules in these voxels. And so it's a scalar metric. So it's 0 to 1, and gray matter is typically less than 0.2. While white matter is more than 0.2. Some people even say that this is the threshold around 0.2 is where you have white matter versus gray matter. And we really don't know where this FA calculation is coming from. Is it truly from the exolemma or the myelination? Is it extracellular fluid, or is it intraaxonal fluid? We really don't know. And so let me make it sort of obvious that there is a certain level of hypothesis behind this, where we say that this has to do with organization of white matter tracks in the structure that you're looking at. And there are different studies done in, say, spinal cord injury, and a lot of work coming out of University of Wisconsin, Milwaukee, where initial compression on a neural structure leads to increased FA. So tightly bound axonal tracts, you apply external pressure on it. The water molecules tend to have even more anisotropy, and so the FA increases initially. But if the pressure is maintained for some time, and this leads to irreversible changes within the neural structures. For example, you could have hemorrhage inside, axonal loss, neurodegeneration, or demyelination. Then the FA can actually decrease. The diffusion water molecules can be uniform again. And then finally, in the recovery phase from a neuronal compression, if there is reorganization and neuroplasticity, and I'm going to say that neuroplasticity, good or bad, we don't know. If there is reorganization, then the FA can increase again. So it can go in multiple different directions. And this has implications into when we should measure FA, depending on the natural history of the disease. So understanding the overall complexity and the assumptions that we know, we put forward a hypothesis saying that the site of brainstem compression immediately proximal to the foramen magnum should have increased FA because there is compression from the cerebellar tonsils. And the sub-hypothesis was that with surgical decompression, it should resolve. If it is true, it should resolve. And so we tested this hypothesis in 8 patients with Chiari 1 malformation and 16 healthy controls. We chose the 1:2 case control design because the number of patients is limited, and we wanted to have some power to detect the difference between the two groups. Surgery was posterior fossa decompression with duroplasty, tonsillar dissection, or buzzing, depending on what the state of the tonsillar herniation was. And patients had preoperative imaging and postoperative imaging. And the post-op imaging was more than 3 months. So this is a state where most of the acute FA changes have resolved already. All these images were obtained on 3 Tesla MRI using GE. And the DTI protocol had 60 directions of diffusion. And the voxel size was anisotropic. So this is a limitation of the study. I'll highlight that later. It's 1 by 1 in XY plane and 3 millimeters in the Z plane. And the structural imaging was about 1 millimeter voxel size. And we had a blinded clinical information assessment. So the people who did imaging analysis were completely different from the ones who were doing clinical information analysis. And we assessed the severity based on CSI. As you have heard about that already, it's a grading of Chiari based on the clinical presentation and the tonsillar herniation and the size of the sittings. And 1:3 is the grade. Higher the number, the more severe Chiari symptoms and clinical signs. And then Chiari outcome score that we also heard a little bit ago, 4 to 16, and higher the score, the better the outcomes. And so there is worsening and no difference, and then improved postoperative outcomes. And we analyzed the data using 3D slicer, standard sort of pre-processing steps, and in the structural metrics, we looked at the degree of tonsillar herniation in mid-sagittal slice, ACPC length, volumes of the whole brain, posterior fossa, the volume of the fourth ventricle, superior compartment, inferior compartment, the angle of the tentorium, and then we looked at the FA values, average FA values, in 2 slices just above the foramen magnum, and I'll show you in a slice, next slide. And then we calculated that separately for the anterior and posterior compartment. And so this is how we did the FA calculation. Presumed site is foramen magnum. Just above that, we calculated an anterior and posterior compartments. And the reasoning for the anterior and posterior compartment was that posterior compartment is closer to the fourth ventricle and the central canal. And so sittings related or fluid dynamics related changes are more likely to affect the posterior compartment than the anterior compartment. Then the inherent sort of architecture of these 2 areas is different. So anterior compartment is more white matter tracts, the pyramidal tract, lemniscus, and few gray matter nuclei in that. While the posterior compartment has more gray matter nuclei and less white matter fiber tracts. So if you look from an FA standpoint, these 2 areas should be different. This was the reasoning why we divided anterior and posterior compartments. So this was the cohort, 8 patients, different ages. All of them had the typical suboccipital headache that got worsened with Valsalva maneuver. Some of them had myelopathy, and 3 of these patients that I highlighted with START, patient ID 2, 4, and 6 had sittings as well, and their severity on Chiari Severity Index is listed as well. And these patients had follow-ups that varied from 3 months all the way to 29 months, and their outcomes on the Chiari outcome scale are listed as well, along with any persistent symptoms if they had. And so, for example, this patient had persistent burning pain in the posterior neck. This patient had a cervical sittings. The patient with sittings, again, with persistent headache and hemibody numbness. And patient number 6 continued to have persistent pain as well, along with numbness. And these are the 3 patients who had the sittings in their initial presentation. So in the structural metrics that we compared the 8 Chiari patients with 16 age and gender matched controls, we found that, of course, the degree of tonsillar herniation is significantly different. But after that, none of the structural metric was significantly different between the 2 groups. So the ACPC length was same, total brain volume, posterior fossa volume, the volume of the 4th ventricle, both superior and inferior compartments, and finally the tentorial angles. All of these were quite similar. There was a trend towards smaller posterior fossa volume. It's not statistically significant, but I'm not sure if increasing the sample size would show some of the real underlying difference there. And so this is the summary slide for the results, and I'll show you the pictures in the next slices. So the important finding was that the FA was higher in patients with Chiari 1 versus controls in the anterior brainstem compartment. So in the anterior brainstem compartment, which has predominantly white matter fibers and there is compression, probably there is increased anisotropy because of external compression. And so the FA is about 0.1 difference between the Chiari patients and controls, and this was statistically significant. The other interesting thing that we saw was that the FA normalized after decompressive surgery, except for in situation where patients had sittings. So in patients with sittings, the FA actually increased post-operatively by about 13%, but those without sittings, it decreased, and this was statistically significant. That in patients who had sittings, potentially these patients were reorganizing afterwards, so their FA was increasing. While in patients who did not have sittings, the FA values decreased because the external compression was taken away now. There was a trend in anterior brainstem compartment in the same direction, but it was not statistically significant. And so this is the first slide. So on the picture on the left, this is FA value, and these are the different cases. The cases are listed as bold circles, while the controls are gray. And on the figure on the right hand side, you can see the average values and the 95% confidence interval. So if we zoom into this, the FA values are higher than controls in Chiari patients, higher than controls in 6 out of 8 patients. So you see the solid dot is higher in 6 out of 8 patients. In patient number 2, it was between the 2 controls. This is a patient with sittings. In patient number 5, again, it was close to the controls. And this is anterior brainstem compartment. So on an average, anterior brainstem compartment, the FA value was higher in Chiari patients than controls. And in posterior brainstem compartment, the picture is much more difficult to tease out. And so the FA values are sometimes very close, sometimes in the middle, sometimes lower, and so there is no significant difference between the 2 groups. And so the resolution post-op, so y-axis is again the FA and the x-axis is the patient ID. So pre-op FA is in blue and post-op FA is in red. So if you see red, that means the FA increased afterwards. If you see blue, then FA decreased afterwards. So you took away the external compression, the FA decreased, so you'll see more blue. So in patients with sittings, I listed all of those in the beginning. Either FA increased afterwards, or there was no change in FA, while in patients who did not have sittings, the FA decreased afterwards. And this trend was statistically significant in the posterior brainstem compartment, where in patients who did not have sittings, the FA values normalized after decompressive surgery. So having said that, I want to upfront highlight the limitations of this study. So it's a very small sample size, 8 patients, 16 controls. The DTI voxel was anisotropic. As you saw, it was 0.8 by 3 millimeters. Typically, we would want to have an iso voxel. We did not do upsampling or downsampling just because this is a acceptable technique in neuroimaging analysis, but we really don't know which direction these post-processing steps shift the data. The other major limitation was that the follow-up imaging was in a single time point post-op, and the timing was variable. It was more than 3 months, but it could vary from 3 months to 6 months to 8 months, and so it was not a uniform sort of follow-up imaging protocol. And then finally, we placed these ROIs in the anterior and posterior brainstem compartments, thinking that it's easier from a clinical standpoint in future if someone wants to replicate. But these large ROIs don't have very specific tract-based information, and so we really don't know if the pyramidal tracts are affected more than the lemniscus, or the vestibular system is affected more. And so this led us to several questions again, and the first question that we encountered is, can brainstem FA evaluation be useful in patients with Chiari 1 malformation in diagnosing them? And the answer to that question is we don't know. And so this will need to be addressed in a larger study, and I'll sort of lay out for you what I think would be some of the design points for the larger study. But based on this investigation, we have some ideas. So one idea is that maybe the single assessment of FA is not enough. Maybe you need FA assessment, multiple of those over time. And then, then we need this assessment under external stress where patient symptoms get worse, flexion extension, Valsalva maneuver. And so maybe using different paradigms to really tease it out in state of compression versus not a state of compression. And then we do understand that patients with sittings are a little bit different. And so a future study should have a completely sort of separate arm for patients with sittings. So it should be a separate group that should be studied separately. And then the other interesting thing that I wanted to highlight is that that it was a significant research interest for Dr. Hudai's lab, and all the patients that she was operating on were having these MRI images. And so out of 20 consecutive patients, only 8 had neuroimaging that was suitable for this kind of analysis. So it's a very tough proposition, and when you start to look at brainstem and even lower brainstem measurement of FA, it has limitations. It has inherent limitations. So we heard about the motion, even though it's a micro scale motion, but there is still motion that can affect a lot of your FA measurements. The second challenge is there is big sphenoid sinus right in the middle that has artifacts that spill over into this region, and so measurement of FA in this region is limited. And so we were having the discussion in the morning about adding these imaging protocols to a lot of these patients. These imaging protocols have to be checked in real time to see if the acquisition is right or not, to see if this imaging will be useful at all in future for any kind of analysis. And so this is a limitation that needs to be discussed and highlighted. And then the second question was, is it useful for assessing the adequacy of surgical decompression? And so right off the bat, we know that it can't guide any type of intraoperative decision making. If someone wants to just do posterior facet decompression without duroplasty versus someone wants to do even duroplasty, how do you assess these things intraoperatively? And it's very difficult based on these measurements alone. And so how would we design an ideal study to look at this in patients? And so I was thinking of several design features, and so it'll be a larger cohort for sure. And if you look at the sample size calculation, in order to detect a 0.1 difference in FA in so two groups, you need almost 17 patients each. So 17 patients, 17 comparative group. So you need a larger study to look at these differences. And the selection of control groups has to be different as well. So healthy controls is one control group. We also need patients with tonsillar herniation that are asymptomatic to really compare what external compression does to brainstem FA in absence of any symptoms. And then FA measurement has to be at multiple time points. So FA measurement is directly affected by patient's blood pressure. And so if it is affected by patient's blood pressure, we need to measure the vitals and make sure that we are assessing this reliably over time. And then if I were to do this analysis today, I would use an entirely different set of analytical tools. I would use a whole brain FA and use these TBSS, tract-based special statistic kind of analysis to look at voxel-wise which areas light up or which areas really stand out statistically significantly differently in patients versus the control group, whichever it would be. And then I would try to correlate it with tracks, specific tracks, and so overlay the known brainstem atlases and highlight which are the tracks that are more vulnerable than the others. And then I would try to also include groups with multiple different surgical interventions, so not just posterior fossa decompression with duroplasty, but maybe even without duroplasty as well. And finally, the holy grail is going to be to correlate this with the severity of Chiari symptoms and how the patients did afterwards. And then maybe even try to have some electrophysiology correlation so that intraoperatively it could guide decision making for surgeons as well. And so these are some of the thoughts, and I'd love to hear from the experts in this room if they have any comments on this.
So thank you very much, Dr. Krishna. Fascinating work. Any questions for Dr. Krishna? Dr.
Fascinating study. Do you know, the part that I thought was most intriguing were the 3 patients with the syrinx. Did that syrinx, do you know, did it get smaller after surgery?
Yep.
So it did shrink,
yep.
But you still found the differential effects.
Yeah, so all 3 patients had resolution of their syrinx, and none of them required a intervention for the syrinx itself. So after posterior fossa decompression duroplasty, it resolved eventually. But yes, and then the other thing is in relation to the resolution of their syrinx, we really don't have whether it was early during the resolution or later in the resolution. So that part we are not clear about just yet.
So the next question is, why do you think, what was the mechanism? How could that be possible?
Yeah, it's a unanswered question right now. And the best educated guess I could make is that maybe there is reorganization, regeneration in patients with syrinx in the posterior brainstem compartment. Really can't say good regeneration or bad. Really don't know.
I want to second those comments. Excellent talk. This is one of the things I liked is you, as a scientist, you really were very cautious to say that you got to be really careful with the results of DTI. But I guess my comment or question to you is, I think it's wise to be very careful. But we don't really have anything else that would be the number 2, right? At least from an engineering perspective, I think of DTI as really the only way that we're going to non-invasively know that there is damage inside, except for symptoms and having them walk, look at their gait, all these other external things. But you want to look on the inside. You know, like me looking at tissue motion, right? It's very nice. I'm looking at the strain. But if it doesn't result in any DTI or damage, then what can I say? You know what I mean? It's sort of I guess my question to you is: Are you hopeful that DTI is going to get better so that you can have confidence and not have a whole thing limitations.
Yeah, no, I agree with you. DTI is the only non-invasive way of looking at microstructure in the CNS at the moment. And I'm a big DTI enthusiast, so I have a whole bunch of papers in functional neurosurgery using DTI for stereotactic targeting, even using for lesioning and showing the safety using the DTI. And knowing all the limitations I know of DTI, it's one of the most useful technique, and it really puts us to the next level in terms of, if you do it right, yeah, it gives you the answers. So I'm really hopeful. Definitely I'm really hopeful, and the kind of work that you all are doing, we're sure to get some of the DTI metric that will be useful, clinically useful for these patients.
I can just make a comment. So, we've used DTI for hydrocephalus quite a bit, and it turns out that we really don't see resolution of signal for FA or mean diffusivity until about a year afterwards. So I wonder if some of this ring bialia question is you're just querying too early in the process of recovery.
Yeah, so this is an excellent question. And so when I do focused ultrasound thalamotomy and I look at the FA changes after thalamotomy lesioning in these folks, some of the persistent changes after thalamotomy really show up after 1 year. So I agree with you that some of the acute changes that are happening may be too difficult to answer with this technique right now, and maybe the noise is much less and the signal is a little bit more, and so you can pick it up in a delayed way. So I totally agree with you. We need multiple time points to really resolve this issue.
Okay.
Thank you.
Thank you once again.